Welcome back to the Cultural Curriculum Chat podcast, where we talk about culture, leadership, and the systems that shape our lives, especially the ones that were never built with us in mind. Today's conversation is one I believe everyone needs, whether you're a patient, caregiver, educator, parent, or someone trying to make sense of AI, healthcare, and equity without all the jargon. My guest today is Eugene Manley, a cancer scientist, nonprofit founder, Black healthcare advocate, and STEM mentor who lives at the intersection of biomedical science, AI, cancer care, and real people's lives. Eugene helps us understand what's actually happening in cancer care right now, how bias shows up in data and algorithms, and what patients and families can do to advocate for themselves, especially when they feel unseen or unheard. Eugene, welcome. I'm so grateful you're here today.
Thank you so much for having me on. You have such a great show. So I'm hopeful that we'll have a conversation that will resonate with your audience and they can have some key takeaways that they can use as they navigate their own issues.
Thank you so much for that. And yes, let's just get into it. You have worn many hats: scientist, advocate, founder, mentor. When did this stop just being a career for you and became a mission?
That is a very great question because, I spent most of my life, I grew up poor, first gen, underserved, and I saw how healthcare was and wasn't delivered to my family. And then, I went through academia and I was, it wasn't so much going through the motions. I really wanted to be a professor. And then I just wasn't able to get support to get grants written. So I said, I need to get a job because I need income. So then I transitioned to the nonprofit space. Now, when I started my first job in a nonprofit in 2000, you could have never told me I was going to launch my own nonprofit. That was not remotely on my radar. But as I progressed through these organizations and I saw similar trends that I saw in academia and I saw in healthcare, I said, okay, there's a massive need to get information to diverse and underserved populations. One, to help them understand how to get in STEM fields to navigate those career transitions. And then two, how to get information and resources to patients so they can better advocate for care they're entitled to. So that's in essence what led to the orbit. It was never on my radar that I was going to launch a nonprofit.
Oh, it isn't that funny how it just, like you said, your observations growing up in your family, seeing how patient care and those touch points really were, and then again saying, I feel like, yeah, God's, when you get that how you say it, rejection, it does redirect you into the what your real purpose is founding that, nonprofit. And tell us more about your nonprofit, how you founded SCHEQ.
So SHEC, which is SCHQ, stands for STEM and Cancer Health Equity. And broadly, the mission is to increase STEM workforce diversity and to improve outcomes for underserved populations navigating the cancer care continuum. So that's the big, long term goal. This all
Mhm.
cannot be done at once because that would be crazy. But what we're really trying to do is address structural and systemic barriers that hinder underserved, diverse scholars from going into STEM, hinder them from advancing in STEM, and then hinder patient care delivery. So we do stuff where we try to talk to kids about STEM careers at early ages so they know there are people like them in these spaces because often you don't see it, you don't think you can do it. We help scholars, particularly low income first gen, navigate college, those career transitions, because often you don't know there's a grad school, you don't know there's a PhD, you don't know there's a postdoc. And often you're still behind the ball. We're trying to understand academia and then what career paths you can do because university doesn't always tell you the career paths that you have. So we try to, I try to develop and mentor people to know what you can do and don't just be limited by what they tell you. But then if we can get
Yes.
more people like us in the workforce, then we can start addressing bias in care delivery. There's, patients have such relief when they see providers that look like them, because often we don't. And so you
Yes.
have all this stress and pressure that you're dealing with. And then lastly, um, we do infographics to break down medical information because the thing my mother dealt with so much is to go to the doctor, once she'd be ignored and mistreated, and then you get report or write up in my chart and say, oh, well, the instructions are on my chart. It's on page 5. Who, if you don't have a medical background, is going to get through 4 pages of jargon to get to page 5? So take the time to explain it. And so since they don't, I decided to start creating infographics to break down medical terminology and cancer terminology. And we're slowly building that up. And we do a lung cancer annual conference, really focus on diverse and underserved populations so they can meet people that are working in the space that are actually trying to create solutions to the barriers and not just talk about.
Yes, and I love that because and it's so hard, especially like the software in the portal of My Chart. They have that assumption that you are tech savvy, you understand, like you said, the medical jargon, and to create those infographics for people to really still deliver the same information, but in a more palatable way that they can understand what is actually going with their care. Because you're right, it feels like it's very triage in a way of like, yep, we saw you. You can leave now. All the information is in your My Chart. And it's like you have to give away like your firstborn child just to get a new password. It's so
Yes.
it is so frustrating. And again, for our elders and for people, like you said, that just need to understand their own patient care in a way that you don't need multiple degrees to actually read what the comments were in your doctor's notes and things like that. That's amazing what you're doing. Um, we let's talk more about what should patients do because you talked about your mother feeling dismissed and misunderstood. What should patients do if they feel misrepresented or dismissed?
This is a tricky, it's not tricky, it's challenging. Because,
Yes.
older generations and some cultures still believe that the doctor is always right. And it's really hard to get people to argue and fight, well, fight for lack of a better term, and say, well, I don't agree with this. And so my mother, she was poor and they just, especially when she was in hospitalizations, the night staff were just terrible to her, condescending, rude. And I saw this even with my grandmother, and it's just it keeps happening to black and poor and underserved, and people act like it's a one-off or it doesn't happen to, oh no, because I have my own story of medical racism with my own surgery last year, which was absolutely bonkers. So things patients can do is you can always go into the doctor's office with a list of questions, like have 5 questions that you want to ask your doctor. If you have a condition that you want some resolution or say, okay, this is a problem I'm facing. What are the possible diagnoses? Then if the doctor comes up with potential diagnosis, is this the only potential diagnosis or is this the one you came up with? Then why did you come up with this? And then what are treatments for it? If they can't give you that stuff, then you have to wonder and think, is that the doctor you need to have? And a lot of people don't understand. You have the right to get second opinions. You have the right
Yes.
to change providers. A lot of people
Mhm.
don't understand or use that power. Like, there's no reason to sit and argue with someone that's not fundamentally listening to you.
Mhm. That part. Yes. And again, to self advocate, I love that with just come with 5 questions. And if you have it written down too, it gives you more confidence as well. Because when you're in there, they come and they say, it's so quick. And you're just like, oh man, I forgot to ask them this. Or have another adult or advocate with you in the room that you trust. So then they can help ask the questions if you don't feel comfortable. But I love that, you know, doctors are also human and they also look at charts and data and try to figure out, and you're in some subset, but you also have the right to get a second opinion as well. And that I feel a lot of us are like, well, they said what they said. This is the outcome. I got to go deal with. And it's like, no, you don't necessarily have to do that one way. Oh, I love that, Eugene. And okay, let's talk about AI and cancer care too, because AI is already shaping cancer care. We've seen it all over. Where do you see it as helping, and where is it quietly making disparities worse?
Well, at its root level, AI is really just analysis of data that's either out there or being developed, and it looks at trends, variances, um, variations, and at its root level, it's data in, data out. So if you put garbage in, you get garbage out. So that's the
Mhm.
problem. Most of the data is not built on or developed on diverse and underserved populations. Most of our databases are based on European based data. Most of our therapies are based on European based data and gene sets. And then we have these things translate through to trials and therapies, and you wonder why they don't work. So where AI, is handy in healthcare, a doctor has a lot of patients and they want to be able to, to get through their medical charting. So voice to text, fine. Sometimes it flags stuff you miss. Other instances, robotic surgery. So sometimes robotic surgery can be done not just in lung cancer, but it often is done in lung cancer. So you can do more minimal incisions. You can use the camera and the scope and sort of have very fine controlled movement to help you do surgery faster and then allows patients to recover faster.
Mhm.
Some instances, there's in lung cancer, we have, even though it wasn't originally designed this way, we have low dose CT, which is a chest CT scan of the lungs for those at high risk of lung cancer, which tend to be those with a history of smoking. Low dose CT has been shown to be a good early indicator of lung cancer. So the guidelines said you can be screened for lung cancer if you have a history of smoking. However, the bulk of that data set was not diverse at all. It was not diverse populations, period. Though recently an algorithm has been developed called Sybil, and I'll try not to get jargony, but Sybil is an algorithm that will look at low dose CT scans. And typically, a person is scanned at least once a year for 3 years, sometimes longer. And the Sybil scan was able to predict a patient that would have lung cancer 5 years, up to 5 to 6 years, based on a previous scan. So it could look at the chest X-ray and say, predict the patient would have cancer. And then, but this whole data set was not diverse. But what they did that was unique and good is that then they tested it in other data sets. They tested it in a data set from University of Illinois Chicago, which is a federally qualified health center with a heavy Black and diverse and underserved population. It was tested, validated at Harvard Hospital. Then it was tested in a group in Korea. And in all these different groups, different populations, they still were able to pretty well predict lung cancer up to 5 years prior based on a scan. So it shows that there is some potential to do disease diagnosis. That's a rare win and use case scenario. But often what happens is we have these investors or developers come up with a product. We have this solution to the problem that does not need to be served. That's the best way
Mhm.
to describe it. So everyone's, we're going to get them an AI training. And then you look at the design teams, the staff, the leadership, and I'm like, okay, and who is this designed for? And then you have
Exactly.
things where we have like, the pulse oximeter is not working on black skin. We have different things in dermatology not working on dark skin. But worst case is when you have someone that says, oh, we have an algorithm that can detect dense breasts as a predictor of breast cancer, because dense breasts are associated with breast cancer. And then you look at their training set and test set, and the training set was a group of suburban affluent women at a major medical center. And, on the surface, like, oh, we got a solution. So, and then your whole test set is another set of suburban women that were not in the original trial. And then you're like, okay, and how do you think this is going to be broadly implemented when, if you have done your due diligence or understand the space of breast cancer, you would know that Black women tend to have dense breasts, and that's why they tend to have increased risk of breast cancer. So if you've not done that part, you completely have not a product you can use. So this is the worst case, and this is often what happens, everyone's going to push to get something out and solve the problem, but you did not solve the right problem.
No, no. And again, they want it to be a catch-all, but everything has nuance in it. And like you said, and yeah, it is. It's a blessing and a curse in some things. And I feel like the people that are developing these algorithms in the sense and they're not looking at all the multiple skin tones and all the densities in our bodies and our tissue and that can, yeah, like you said, could have a lot of people getting misdiagnosed and not catching the cancer in time to be treated as well. So, oh, that is just yeah, we've got a long way to go, like you said. Oh, goodness. So we've talked about, especially cancer in our Black communities. And like you said, how it disproportionately impacts our Black and low income communities. And you talked about that Sybil algorithm and AI tool. Let's also switch gears as well as um, thinking about when it does come to screening, what can we do now? In these underserved populations and communities, do you suggest we continue to ask, like you said, to advocate for ourselves, get the second opinion? Is there another thing that we should keep in mind too when it comes to screenings?
Yes. So for screenings, I forgot to mention one thing, and you brought it up when I talked about navigating care. You have the right to bring a medical proxy with you to any appointment. So you alluded that, and you said you have someone that can understand and read the records. It is actually in your best interest to bring someone with you that can understand medical terminology and jargon, because sometimes when you're in the middle of a diagnosis or results, your brain's not there and you're not grasping stuff, and you need someone that can objectively sort of make sure they're saying stuff that's right and appropriate and they're not dismissing you. So you need that person to hold them to task. Because when they think you can hold them to task, they're more likely to give you accurate and guideline concordant instructions. And I think you had asked about what else they can do in care. So, one, you can self advocate. In lung cancer, we now, as of I think last year, allow billing for nurse navigation.
Yeah.
So, and that's a blessing in a curse. So now it can be billed, but then that still can transfer the cost for people that don't have it. But what nurse navigation does is they are often the link between the patient and the clinician surgeon. So the navigators will help the patient understand the disease, be able to ask the questions, answer questions, help connect them with resources. So they play a vital role in care delivery and transfer. So if you have a navigator, it is great, but not a lot of places have it. And that's always a big barrier. I would also say when you're navigating care, make sure you understand the disease, make sure you understand all the treatment options, not just the one they tell you. Make sure you ask about biomarker testing if it's available. In lung cancer, there are about 11 biomarkers that are approved. Most people, if they're lucky, only get 3 of the biomarkers tested. So they should be asking for next generation sequencing. It's expensive, but it's a right because there's no reason for you to have a diagnosis and not get testing that could then possibly give you a treatment that would extend or save your life. You should be able to request, I don't know if you can get it, but you should be able to request biomarker testing and you should be able to ask about clinical trials. We see that underserved populations often are asked about clinical trials or biomarker testing, but you're within your right to ask that provider, are there any clinical trials that I can go on for this therapy? And sometimes clinical trials might get you a therapy that might be new and developing and it might help you, it might not, but so many people don't know about trials and they don't know how to ask about them. And the flip side is, well, we've already been experimented. Some people have the fear, we've already been experimented on. Why should we do it? And that is a real concern. But at the same token, if we don't have more of our people in these trials, then we will never really get therapies that impact our communities.
Exactly. Oh, I know. And that's a whole nother episode of historical medical trauma. i.e., look up the Tuskegee experiment and you'll understand. That's one big one. But you're right. I feel like the options are there. But again, if you don't have a proxy, medical proxy, like you said, or even that service, that nurse net, that nursing network thing, that you won't know unless you ask and advocate. And I love you. We have to hold them to task, because your life is your top priority and your medical care. And some of us, like you said, in those underserved populations, feel like they don't have the, I don't want to say capacity, but they don't feel worthy enough to ask for it because of how they've been treated in the past. A lot of people would say, "Oh, it's easy. Just say I'm going to do this and I'm going to do that." But it's like, when if you're from that population, you've been conditioned to say, "This is what you get, and don't ask
Yep.
for anything else." And so they're still thinking in their own lived experience of, how can I still advocate for myself and have my dignity, when others that are supposed to be taking care of me don't see me as a dignified patient, right?
Yes.
Did I
Yes.
get what you're
Yes.
throwing
Exactly.
down?
Yes.
Okay.
Exactly.
This is before coffee, people. Yes, I got that. I love it. But also, yes, thank you. I mean, I really love this conversation, Eugene, and just helping how we can advocate. I love how you're getting underrepresented groups in the STEM fields. I'm a former classroom teacher, and just to see representation of our young folks coming into the medical, sector, it does make you feel like, oh, I can just relax a little bit. This person sees me as an auntie in the chair, or an elder or a friend. It just makes you feel more comfortable when you see people represented of your community in the front lines, helping you. I just really, let's do more about this STEM career real quick. Um, because we're, STEM and medical equity is so important. How can classrooms, for our teachers listening, experience and shape future care with their students?
I think there's multiple ways,
Hmm.
depending on where you are, there may be some pre-college engineering programs, there may be some science programs. There's often, science demos. So sometimes you have to hunt for them, unfortunately, but those are things, generally we post daily for Black History Month and Hispanic Heritage Month, just so people can see kids from the diaspora. But my life has been really chaotic, so I've done nothing this year. So I cannot
Okay,
believe
it's
admitting, I cannot
all
believe I'm
good.
just admitting that. So,
It's all good.
but the last two
Just
years,
stays between you and
we
me, right?
did. But we
Yeah.
want people to see people from their community or the diaspora that, you don't necessarily have an advanced degree, but just to know there are people that have done it so you can do it, and trying to get, but getting them that early exposure to STEM. I grew up inner city Detroit. We didn't see anybody in the hood doing medical stuff. But I would say if you want the kids to really do it, this is not psychological data. I would say you want to engage the kids around third grade. At that point,
Mhm.
they tend to be somewhat receptive and will listen. And then if you just give them a little nudge and they go, I want to do this. And if you expose them, those that will likely pick it up will likely stay with it. But if you wait till fourth or fifth grade, then at that point, they've gotten into video games, extracurricular activities, sports, and then it's not cool anymore. And then even when you are an inner city kid doing science stuff, you get teased, but you just got to learn to work through it and just sort of know you have a mission and stay on task for your mission, because the world would always tell you what you can do. So you have to move your own way forward.
I love that. Oh, I love that, Eugene. Where can our listeners and viewers on our YouTube channel find your amazing work and your nonprofit so they can support you?
So we can be found on website is scheq.org. We have social handles, our LinkedIn, Instagram, Facebook are STEMMCHEQ. I can also be found on LinkedIn as Eugene Manley Jr., so you can follow me there. And if you find my Instagram, it's Eugene Manley, but you just have to tell me because I have it locked. Because I don't really use my Instagram for my social work. And
Yes.
and we also have just launched an LLC that I don't even have a website for yet, called Innovation for Impact Consulting. So it is part of the arm and I work to do grant writing, program development, and public speaking stuff. So just trying to leverage all the other skill sets I have and how we can help do organizational transformation, help scholars navigate career transitions, and then, help people, maximally do what they want to do.
Oh my gosh. This is amazing, Eugene. And again, it's just a blessing that you're doing all this work. One real quick question. How do you stay grounded? Because this is an emotional, heavy, type of field you're in, helping patients understand. And a lot of them get really tough diagnoses, and how do you keep going and stay grounded without being burnt out?
It's, doing this work in and of itself is exhausting on its own.
Yeah.
You're always trying to get grants, trying to get funding. And right now we're in a major anti DEI phase. So it's even harder.
Yeah.
It's even harder to do the work,
Preach.
but you still know the work needs to be done because if you ignore these populations, who else is going to help? We are having reductions in minority people applying and getting in med school, and that all because well they're not qualified. I'm like, so you're gonna bring in a bunch of doctors that aren't from these communities, and then we're gonna just have them get mistreated because well they're not smart. It's like that's not a good reason. We in this country have done so much of preventing black people from getting education, from one enrolling in school, getting in professional schools, and now we have something to allow us to get in because we still need people from these communities. Now that's trying to be taken away, but the work still needs to be
Needs
done.
to be done.
So how do you say it's grind is just understanding who you're trying to help, why you're trying to do it, and the overwhelming need. And I've always been humble, which is hard. You can't teach humility. Um, you can try, but you have to be humble or you're not.
Yes. Exactly, exactly. Oh, yes. Oh, Eugene, this is just an amazing conversation. I could talk to you all day, and it's the mission, just what I'm hearing you say, the mission is great. And I'm so happy and grateful that you are one of those helping the charge and helping you share your knowledge with the rest of our listeners here is going to continue to keep that mission moving forward. Thank you so much, Eugene, for this conversation and for your commitment and clarity and justice in the medical field. And those of you are listening today and watching on YouTube, be sure to share this episode with a family member, a friend, an educator who's just trying to figure out how we can best serve our neighbors in our community. And until next time, I will see you here, same time, same place. Bye bye.
Thanks for having me.
Yeah.
Navi.